Support for your public radio station comes from our members and from Mary Cariola Center, proud supporter of Connections with Evan Dawson, believing an informed and engaged community is a connected one. marycariola.org. And Great Thai Consulting, providing management consulting services to help support not-for-profit organizations. Services include C-suite staffing support, executive coaching, and business and fund development. More at greatthaiconsulting.com.
From WXXI News, this is Connections. I'm Evan Dawson. Our connection this hour was made 10 years ago when I sat down on this show to talk with a doctor who was choosing to leave Rochester and move her family to Canada. She said at the time that the American healthcare system was crushing her soul. She loved Rochester. She loved her patients. She was torn up about the move. But ultimately, Dr. Emily Queenan said that when she went to school to become a doctor, she did not envision spending so much time on paperwork and wrestling with insurance companies and struggling with reimbursement questions. She wanted to spend more time with patients. She wanted to build long-term relationships. She wanted to be a doctor, not a cog in a medical business. During that conversation on Connections, Dr. Queenan said it was not impossible that she could someday return to the United States to practice. That could happen if American healthcare changed. At the time, the Affordable Care Act was still relatively new, just a few years old, and she had cheered its passage, hoping it would make medicine more accessible in this country, but it wasn't enough. Not long ago, a listener recalled that conversation and asked me, whatever happened to that doctor who went to Canada? And so I reached out. And the answer is Dr. Queenan is still practicing in Canada, and she is still generous with her time, generous enough to come back to Connections to review her monumental decision a decade ago and to maybe diagnose current problems that she sees in healthcare. We are glad to welcome back to the program Dr. Emily Queenan. Dr. Queenan, it is so nice to talk to you. How are you?
I am doing well. It's such a pleasure to talk with you again, Evan. I appreciate you asking me to join.
I want to make sure I've got, your professional titles correct. You are a family physician at Queenan Family Medicine and Maternity Care in Midland, Ontario. Is that part correct?
I am. I have a comprehensive family practice, meaning cradle to grave, primary care along with primary care GYN care. And part of that practice involves transgender or gender affirming care for transgender and non-binary folks, along with reproductive health care involving medication, abortions, and palliative care, both at home, hospital, and at hospice, also involving medical assistance in dying, all under the umbrella of that Queenan Family Medicine and Maternity Care.
And president of the Professional Staff Association and chief of obstetrics at Georgian Bay General Hospital. Is that right?
Yes, we are a mid-sized hospital in Midland, Ontario, and Georgian Bay. I've been the president of our professional staff association, meaning I represent the physicians, midwives, and dentists at the hospital in working with the hospital administration and the like. I've done that for the past 5 years, and then I've just recently stepped into the position of chief of obstetrics of our hospital.
Okay, so very busy, and just to kind of give people a geographical location, from what I can tell, Midland looks like what are you, about an hour and a half north of Toronto?
Well, it depends where you're going in Toronto, about an hour and a half from the airport,
Okay.
but a couple hours from downtown. Directly, there's a highway that everyone knows who's coming up from Toronto called the 400. If you take the 400 till it ends at Georgian Bay, you'll find us.
So you are at the northern end of where Canada feels bearable this time of year to me. But I'm
and barely not quite northern Canada, most definitely. We are central Ontario.
So listeners, if you've got questions, comments this hour as we talk about maybe the differences that Dr. Queenan sees between Canadian healthcare and American healthcare, her decision to leave the United States for Canada 10 years ago, what that has been like. If you've got questions, comments, there's lots of ways to do that. You can email the program, connections@wxxi.org. You can call the program toll-free, 844-295-TALK. It's 844-295-8255, 263-WXXI if you're going to call from Rochester, 263-9994. If you are following on the WXXI News YouTube page, hello. You can watch the show there, and you can join the chat there if you want to offer thoughts or questions or comments for Dr. Queenan. We're going to start with sort of the broad question, and then we're going to get much more granular, Dr. Queenan. But I'm sure a lot of people want to know, 10 years later, Any regrets? Do you regret moving to Canada? What do you tell people?
Not once. I moved for a values proposition, and the values proposition is that in Canada, healthcare is valued as a human right. And in my view, unfortunately, in the United States, healthcare is rarely viewed as a human right, but treated as a commodity. And it was that values proposition that brought me to Ontario, Canada. And while certainly there are struggles in our system that I'm sure we will get to, that values proposition is never questioned.
So, boy, we already see the phone ringing. Usually Connections listeners have this pattern where we kind of talk for 20, 30 minutes, and it's such a wonderful and growing audience, and then the second half hour we get a lot of comments. But if you've got comments throughout the hour, we'll take them. I want to make sure people understand a little bit about Dr. Queenan's background. Now, you had lived in Rochester when we spoke in the end of 2014, almost exactly 10 years ago now, at the beginning of 2015. You had lived here for about 10 years. You had your own practice for 5, but not from here originally. Is that correct?
Yeah, I am American. I have no connection to Canada other than our move for healthcare. Neither my husband nor I are Canadian, but we're both from the Mid-Atlantic. I'm from outside of Philadelphia. He's from Delaware. We came to Rochester for the wonderful family medicine residency program where I trained, and then we loved Rochester, so we stayed here. Stayed there. Had 3 kids who are now teenagers. When I graduated residency in 2008, I opened my practice the next year and had the first version of Queenan Family Medicine and Maternity Care from 2009 till 2014.
When did you start thinking about making them? I went back and listened to our conversation 10 years ago. And that's the one question I don't think I asked you. We covered a lot of ground, but I'm curious to know, when you made that decision 10 years ago to move to Canada to practice, how long that had been sort of bubbling up in you, this idea that you couldn't keep doing this. Do you remember?
Yeah, I do, because I had actually quite long grappled with the decision whether I could keep on keeping on in my practice, delivering comprehensive primary care in Rochester, because it was that era of accountable care organizations where small practices like mine, I was in solo practice, were being eaten up by the hospital systems. And it was in many ways very uncomfortable, scary, full of uncertainty, as so much of life is. And I was feeling really weighed down by the commercialization of healthcare. Yet at the same time, I wasn't willing to be taken over. I really prided myself on the practice that I had developed at Queenan Family Medicine Maternity Care. So I grappled with that decision for probably a year or more, feeling this yoke around my neck of my practice, yet not wanting to give it up, really for the sake of my patients and because I actually loved the doctoring part. And then eventually I did reach a breaking point, and within a matter of weeks, I had reached that breaking point and was trying to decide my next steps. And it was actually one night in April 2014, where I think it was 2014 in any case, where I attended a Physicians for a National Healthcare Program meeting and then a virtual town hall meeting with the AAFP. And both meetings led me to realize that the arc of history is long and that healthcare in the United States would be a long time in reformation, if at all. And I realized I wasn't willing to wait it out. I thought I might wait out the American healthcare evolution by spending time in urgent care or perhaps working for university healthcare, but I wasn't willing to do that for the entirety of the prime of my career. And that particular evening, I sat down at my home computer and Googled American physician to Ontario and turned to my husband and said, "What do you think about moving to Canada?" And he said, "Sure." And I said, "No, really this time?" Because I think we had joked about it every time a Bush was elected. And so we started the process that evening.
Listeners, it's your show, so we're going to get calls right away here. As I go to your phone calls and your feedback, I want to set some of the parameters that Dr. Queenan gave us 10 years ago on this program. Dr. Queenan told us on Connections 10 years ago that goals as a doctor: provide excellent care to patients, build long-term relationships with patients, spend more time with patients, focus primarily on patients, not paperwork, get away from the difficulty of overhead reimbursements and everything that makes healthcare not feel like healthcare. And we're going to talk to Dr. Queenan throughout this hour about whether each of those parameters not only has it been checked working in Canada instead of the United States, but what those differences really do look like in practice, because I know listeners want to know. Let me grab a couple of phone calls here. This is Heidi in Fairport first. Hello, Heidi. Go ahead.
Hi, how's it going, Evan?
Very good.
Hello, Dr. Queenan.
Hello.
I just want to call in because you were our family physician when we had our first two sons here in Fairport. You were referred to us
Wonderful. Thank you.
Yeah, and I just remember the time and the care that you took. It is the gold standard for how I measure every other care provider. Like, you were an amazing physician, and you made me feel good as a mom. And I could tell that you cared about us, you cared about our family, you cared about our kids. And every time I see you pop across my news feed on social media, I'm like, oh, I'm so glad she's doing well. But we do miss you very much as a healthcare provider. So I want to say thank you. And I was super excited to hear that you were coming here on Evan Dawson today. So thank you.
Thanks so much.
Heidi, thank you for that. Dr. Queenan, I don't know that there's a better endorsement that you can get. You've been gone from this area for a decade now, and you've got people lining up to call this show just to thank you for the work that you did. That's pretty good.
Yeah, it's really, it brings tears to my eyes. That's what family medicine is about. That's why I went into family medicine, was to make a difference in people's lives. It sounds a bit trite, perhaps, but it is the truth. It is why I do this work, which certainly can be really difficult. It's not for the meek. So yes, thank you, Heidi. It makes the biggest difference in the world to me.
Heidi, that is a really generous phone call. That's we appreciate that call. Thank you. Keith in Bloomfield next on the phone. Hi, Keith. Go ahead.
I have an interesting show. I just got a couple comments just to see what the doctor would say. Time and time again, you always have healthcare professionals, and you refer to healthcare in this country as the problems with the healthcare system. The biggest issue is we don't have a system. We have a healthcare industry. So much so that you go to Syracuse and there's a different healthcare industry there. Or I'm assuming healthcare across Canada, the same requirements exist from East Coast to West Coast within the Canadian healthcare system. The second thing is doctors, if they were to act together as one unit, could get changes very quickly by just start slow treating politicians. So if you got a federal politician who has a stomach flu, yeah, we'll see you in a month. You will get changes really fast. That's it. That's all I had to say.
Keith, thanks for the phone call. Dr. Queenan, you want to weigh in on that?
Absolutely. First, addressing the first comment about wondering about Canada-wide treatment, Canada-wide system. Our health system is provincially regulated, so you'll find the same regulations, guidelines, billings within provinces, but it really can be quite different province to province, and unless there's been unless it comes from the federal Health Act. That being said, I think that there is much more of a development of a system here in Ontario than I observed in unfortunately even Rochester, which is near and dear to my heart. But I saw two hospital systems dividing the country, the city, and really quite separate from one another, without sharing the same medical record or or really anything. Here in Ontario, unfortunately, there's still much to be desired in terms of collaboration across the systems. We still have different medical records from one facility to another. We still have to request records from one city to another. But there is much more collaboration across the silos in a few ways. One, when it comes to making sure that the patient is in the right place at the right time, receiving the right care, there's a coordinated effort to be sure of that. So in a smaller town like ours, where we don't have most specialists or inpatient specialists, often patients might need to be transferred for specialized care in the hospital, and there's a system called Critical to support that. And so there's much more of a sense of collaboration across facilities. I've observed it's not perfect. It's certainly still different facilities are still often going after the same healthcare dollars when it comes from in terms of provincial funding, but there is much more collaboration. And then
yeah, go ahead.
Oh, sorry.
No, go ahead. Yep.
Yeah, and then in terms of I thought his comment, I know it was a bit facetious about slow treating or whatever the politicians, but it brings up for me a real tension that comes that we encounter as physicians, as professionals in the healthcare system, because one might say we could strike, we could take some sort of organized action to enact change, yet that is really ethically untenable for most of us. And I mean, I think really almost all. Like it's just built into our training to uphold our professional ethics of treating all folks who need it. And so I think that it's can be very hard for physicians to enact political change in healthcare, because sometimes that what the push that may be required to do so, it isn't compatible with professional ethics. I think it's a tough situation, a tough thing for us to grapple with.
Keith, thank you for the phone call. We're going to come back to phone calls shortly here. It's 844-295-TALK. If you want to call the program toll free, 844-295-8255. We're talking to Dr. Emily Queenan, who is a family physician at Queenan Family Medicine and Maternity Care in Midland, Ontario. That's 90 minutes plus north of Toronto. And she moved there with her family, with her husband and 3 children, 10 years ago from Rochester after a lot of wrestling with, do we make this change? Dr. Queenan is not Canadian. Her husband is not Canadian. She's an American. She'd practiced healthcare in the United States here in Rochester, but then decided that she'd really just felt a soul-crushing weight by the American healthcare system and chose to move to Canada to practice. And so 10 years later, she's back with us talking about that decision, what she's learned, the differences she sees in systems, and taking your questions and comments throughout the hour as well on our various platforms here. So if you want to email the program, it's connections@wxxi.org. And if you want to join the chat on YouTube, we are streaming live on YouTube every day, noon to 2. So there we are in the WXXI News YouTube channel. Hello if you're watching us. And so a lot of places that you can get on in the conversation. Let me just extend off Keith's comments in 2 different ways, Dr. Queenan. First of all, when he talks about healthcare being more of an industry than a working system in this country, I'm thinking back to 10 years ago when you told us that when you practiced in the United States, you could not tell your patients what individual procedures might cost, not even labor and delivery. And it was different with every insurance plan. It was extremely frustrating, understandably so, for patients. Not just frustrating, but real concerns about whether they felt like they could even afford procedures planned or unplanned. And so I wonder if that is different in Canada. Can you talk to, is there a conversation about what stuff costs? Is there much cost? Again, forgive my ignorance here, but can you talk about the difference you see in that way?
Well, certainly our provincial health insurance covers, the intention is to cover all medically necessary assessment and treatment, all medically necessary care. And so delivered by physicians in hospitals and in the community. And so that means that vast majority of medical expenses delivered in that context will be covered by the provincial insurance, so that physicians know how much they are compensated and hospitals know the formulas by which they're compensated. But we can go to the emergency room. I have teenage boys. We've been to the emergency room a number of times, and we leave when our care is done. There's no signing invoices or the like. Our insurance, and similarly goes for advanced imaging, I think is one place that I often ran into frustration in Rochester. Now the ordering of a CT scan or MRI or nuclear study, the appropriateness is between physicians. As a primary care doc, I may misorder a study where actually a CT would be a better study than the MRI that I initially ordered. So that if it is declined or rerouted, it is done by the one physician to another, and it's not done for cost reasons. It's done for medical appropriateness. While in Rochester, in order to order any advanced imaging, I had to fill out prior authorizations and obtain permission from a nameless medical bureaucrat at insurance companies. And of course, there's a different way of obtaining that authorization from every different insurance company. So I often just didn't order. I kind of gave up on ordering advanced imaging. So very different experience. In Ontario, we still don't actually and have coverage for medications. We don't yet have a universal pharmacare, that we're moving in that direction. And then we also don't have a provincial coverage for therapies and it's covered for the old and the disabled, but otherwise physical therapy, or what we call physio, is not covered and is often covered by employer-sponsored insurance. So there are, along with medications, so that there are still some medical costs that Canadians and specifically Ontarians need to bear.
All right, Alex emails the program and says, Evan, a common refrain from conservatives is that state-funded healthcare in Canada is hampered by inappropriately long wait times for procedures and appointments. He says this conveniently ignores the length of time it takes to receive procedures through private insurance plans in the States. But he wants to know directly, Dr. Queenan, what's your sense of the timeliness in care? Is primary care generally fine, annual visits, medication check-ins, but specialty care, does that happen with more wait times or does that happen further out? That's from Alex, Dr. Queenan.
So yes, Alex, access is really important to talk about. There was just an article I read, I can't remember which newspaper it was in, but that Canada was at the bottom of the list of developed countries regarding with healthcare systems in terms of access over only the United States, which was actually still below Canada. But we are not content to be at the bottom of a list regarding access. And in fact, certainly that is the biggest struggle that Ontarians are having in healthcare right now is access. We don't have enough family doctors. And so too many folks are what we call orphaned or without primary care doctors, so that they're needing to seek their primary care through walk-in clinics, through the emergency room, and sometimes through stopgap measures organized through locally, say through family health teams. So there is a problem for primary care access because we don't have enough boots on the ground. Of course, we're looking at a number of ways of solving that, but it has not yet been solved, including drawing upon the work of nurse practitioners. And then wait times for specialists are also often too long. There are individual scenarios. Certainly, locally, our cancer care is very good. Folks get in to see for necessary diagnosis and treatment very quickly. Same thing with cardiac care, but say to see a neurologist inordinate wait time, which is not okay. And then advanced imaging ebbs and flows. Sometimes we have long wait times for MRIs. The difference is that it is addressed provincially in a coordinated fashion, reallocation of funds and such. It is not addressed behind closed doors at a boardroom of a private company.
Talking to Dr. Emily Queenan about the differences in United States and Canadian healthcare. One more email, and then what we'll do is we'll take our only break of the hour, and I've got a couple of phone calls lined up that I think are right in your wheelhouse to kind of talk about maternal medicine, single payer system. So Bruce, Willa, hang there. We'll get you on the other side of this very short break coming up. I just want to read this email from David, who's listening in Vancouver, Canada. He says, I'd say she's very lucky. One of my graduate students of 20 plus years ago was an immigrant to Canada after practicing medicine for over 5 years in Iran. Despite scoring very highly on the licensing exam here in British Columbia, he was never allowed to practice here. He ended up, after getting his master's degree in my lab, moving to LA, where he was welcomed to practice. He does not like the system he's stuck in now, but he is thankful to be able to practice medicine at all. That's from David in Vancouver. Was it any struggle for you to get licensed to practice in Canada, Dr. Queenan?
Gosh, this is such a timely conversation because it's right now in Ontario, in Canada wide, but especially in Ontario, we're talking about how to smooth the way for immigrant graduates, because it is just not okay that a fully competent, well-trained graduate is coming to Canada and working as a PSW or not in the healthcare system at all. So, David, thank you for bringing this up, and it's certainly something that and they tell us that they are addressing. We have 3 new physicians in my community through this Practice Ready Ontario program. For myself, the Ontario makes it quite a smooth process for American family physicians. Our training is very similar. Certifications are very similar. And so I wasn't required to go through any extra training. I only had to submit my application for licensure, went through a period of what was called minimal supervision with another physician in town for the first year I was here, in which we did chart reviews once a month, and then had an assessment of my practice a year into but with an outside reviewer. And now I'm a fully unrestricted licensed practicing physician in Ontario.
David, thank you for that. Sydney on the YouTube chat tells us on the WXXI News YouTube chat, says, I would definitely move to Canada if I could for many of the same reasons. I am dismayed about the many ways that the United States has declined. I waited too long and now I'm too old to be accepted as an immigrant. That is from Sydney. And Jean is an RN who says, hello to Emily. Evan, please give Emily my regards. It is a treat to turn on the radio and hear Dr. Queenan today. We were on the Integrative Health Committee together, a subcommittee of the Monroe County Medical Society from 2004 until she left town. I have missed you, Emily, as many others do as well. Our committee dissolved some years ago, but many of us remain connected. It's been a challenge for all Rochesterians to work within a 2-system healthcare city. Thank you for all your hard work in Rochester and Ontario. Again, that's from Jean, Dr. Queenan.
Oh, thank you, Jean.
A lot of love for Dr. Queenan. Apparently, a very popular doctor here in Rochester, and 10 years later, after moving to Canada, if you're just joining us, we're talking about the decision that she and her family made at the end of 2014 and 2015 to move to Canada so she could practice medicine at a place where she felt like she'd have more time with patients, wasn't crushed by a system that she just didn't really believe in. And now, 10 years later, we're talking about that decision, what she's learned, the differences she sees. On the other side of this break, more of your phone calls and questions for Dr. Emily Queenan. This is Connections. I'm Evan Dawson. Thanks for being with us on this Wednesday. And let me get a couple of phone calls. Folks have been waiting. This is Bruce. Hi, Bruce. Go ahead.
Yes. First off, Dr. Queenan, thank you very much for taking the time to share your experience with us. My question is about payment systems. Here in the United States, we have a multiple payment system where health insurance plans all have different policies. What is your experience in Canada with a single-payer system? How has that impacted your practice?
Well, thank you, Bruce. That really, I think the biggest, there's several differences. One, billing is much simpler, so that I do choose to pay a biller to submit my bills, especially because it was a lot to learn when I first moved here. But I pay her 2% as opposed to 8% of my payments. And so it's made more complex only by various bonuses and extra payments that are given in order to encourage one type of care or another. I think the bigger difference in my clinical care is that I'm not forced to artificially segment my patient population. In Rochester, there may be one program for Excellus Blue Cross Blue Shield employees of the university, and there may be another program for employees of Kodak, and it made it very hard to do meaningful population health work because at least as covered by payments to physicians, health insurance. While in my practice here in Ontario, everyone is the same. I don't have to segment out my population. I can know that if I make a certain effort on the folks working with the folks with diabetes, that I will receive the same bonus or payment or fee for everyone. So it was that artificial segmentation of the population that really drove me crazy in Rochester.
Thank you for the phone call, Bruce. Let's get Willa in Rochester on the phone next. Hi, Willa. Go ahead.
Hi, Evan and Dr. Queenan. The doctor and I knew each other from the Rochester Area Birth Network before she left. And so I wanted to focus on maternity care for a couple of minutes. New York State was one of the most progressive in terms of maternal rights to health care of their choosing. But back then, but it's since degraded because of insurance companies basically figured out how to get around New York State laws. And with the Dobbs decision, things are even worse. And you'd think, well, birthing mothers are different than aborting mothers, right? Well, that's not true, because when the courts decide that they can decide what's best for a woman when she's looking to end a pregnancy, they also then have the right to decide for a woman how and where and when she chooses to give birth. So things have gotten very bad since the doctor left. Can you tell us a little bit about what birthing mothers have a right to in Canada?
Thank you, Willa. Go ahead, Dr. Queenan.
Thanks. So it's good to hear your voice. Of course, I remember you from the Birth Network. Your question, is right. There's so much to explore in that question. So I'll take it in a couple different ways. One, from a reproductive health care perspective, including abortion care and contraception. The Canada nationwide, federally, has decided to stay out of legislating it, and so it really is regulated through all medical procedures, through the health professions, through our colleges, and that has kept abortion out of the courts. Most recently, I can't predict the future, but certainly now, and so it is regulated, as should all medical procedures are, for appropriateness, and but the courts aren't involved, so that is huge. Secondly, in terms of the rights of birthing people, I've one really dramatic difference for me in my birthing practice here in Ontario is I work much more closely clinically with midwives, because the midwives at our hospital work right alongside me. So certainly there are wonderful midwifery groups in Rochester, and I admire them, but we, at least in my clinical practice, we were a bit more separate, while in my small hospital, my mid-sized hospital here in Midland, we work very closely together. And one thing that I've noted that's so different from Rochester is that birthing people have a choice of birthplace. It is a part of their initial conversations regarding risk, benefit, and alternatives, and in making informed consent as to whether they birth at home or in the hospital. And the midwives have privileges at the hospital and for home birth, and so that the transfer to hospital from a home birth is really seamless, and as it should be. While unfortunately, I didn't see that happen in Rochester. Often the transfer from our home birth midwives in Rochester to hospital was a much more disjointed, not at any fault of the providers, but the system that in which they worked. So those are probably the biggest difference that I've noticed in our birthing systems.
Willa, thank you for the phone call. It's 844-295-TALK. It's toll free, 844-295-8255. 263-WXXI if you're calling from Rochester, 263-9994. You can email the program, connections@WXXI.org. You can join the chat on our YouTube channel, where this show is streaming every day on the WXXI News YouTube channel. Hello to viewers there. And I want to just let you know that the reason we're having this conversation this hour is we're marking 10 years since Dr. Emily Queenan made the decision to leave Rochester, to leave the United States, to practice medicine in Canada for quality of life, for philosophical and values-based reasons. Said her soul was being crushed by American healthcare. She made that move, not just her husband, and 3 children, and they've been there for 10 years, and she said no regrets. It's not perfect, but we're talking this hour about how she sees the differences. So let me work through some of the points you made to us 10 years ago, and then you can you can give me a no difference, small difference, big difference. How's that, Dr. Queenan? You ready for this?
That sounds great.
All right.
Yeah.
You said one of your goals, spend more time with your patients when you moved to Canada than you were able to spend time with patients in the United States. No difference, small difference, big difference.
Gosh, that is an interesting one. I wish I could. Big difference, but not in the direction that I would have anticipated. I actually feel I have less time with patients in my current practice. And that's because when the barrier to accessing care is through the accessing physicians, I live on a day-by-day basis with an extraordinary pressure to accept more patients into my practice. Again, we have too many patients who do not have family physicians, or so-called orphaned physicians. And I try to close my practice, but of course, practice is really closed, and I still accept newborns and household family members and trans folks and the occasional other person. So I think that the time I have with each person, I still schedule 20-minute visits, but I often feel pressured to work faster, see more in order to provide more care to those who need it.
Okay. You said you wanted to focus on the patient, not the paperwork. Small difference, no difference, big difference.
Big difference in terms of finance, in terms of billing and stuff. Unfortunately, the world over, primary care is going through crisis. UK, Australia, the US, we all are struggling with the paperwork that is providing healthcare in this day and age. It's obviously often digital paperwork, but we are living in an onslaught of data, a deluge of documents and labs and reports and emails and all the like, messages, tasks. And so I would say that I probably spend as much time on non-patient facing care as I did in Rochester, but it's more on clinical care than it is, and systems work, working on various committees than the business.
You said you wanted to be part of a system that values patients as people, you did not want to be part of a profit-seeking industry. No difference, small difference, big difference.
Big difference. And it's that values proposition that has led me to stay.
And before I come back to phone calls, you told us 10 years ago that you were you were someone who wanted to see the Affordable Care Act when it was up for debate, that you were hoping it would make positive changes, and that it wasn't the ACA that forced you to leave the United States. But what you told us on that program was the ACA was like a Band-Aid on a hemorrhaging patient. Well, now 10 years later, it is not possible to predict what the next 4 years will bring in healthcare. But I wonder how much, do you still feel connected enough to what's going on in American healthcare that you can weigh in on what you see here and whether it would be attractive to come back?
I have been dispirited by how little has changed in American healthcare. If anything, as Willa was pointing out, some of the legislation regarding what healthcare is allowed to be delivered. Every day, I'm grateful that I practice in Canada when it comes to the legislation of healthcare. So, I don't know if the United States will ever move forward on working to ensure healthcare is a human right. The Affordable Care Act was one step in the right direction, except for in terms of ensuring greater access to care, but it was really no more than a subsidization of the private insurance industry. It allowed my husband to stop working in a job that he was primarily working in to offer our family health insurance. Yet at the same time, it made lives like mine ever more difficult in primary care.
All right, Christopher in Rochester on the phone. Let's get a couple of phone calls here. Chris and Jim. Christopher first. Go ahead.
Good afternoon. Thank you, Doctor, for being on the show today. It's awesome. And good to see you live on YouTube, Mr. Evan Dawson.
It's good to be on YouTube.
Yes. So in the world of gatekeeping, what are you seeing as far as in Canada with regards to mental health care? When folks come in to your practice, in Rochester, it takes 6 months to get an appointment at Strong Behavioral Health. And our governor is talking about some of the explosive issues about mental health care, but you're the first line of defense. You're talking to patients one-on-one, and you notice when things aren't quite right. We spend a lot of focus on we know how to repair a broken leg, and there's a high reimbursement rate in this country for it, but there's a low reimbursement rate in Rochester for folks who may struggle psychologically. What is the difference between the Canadian model of dealing with care in your practice when you come across mental health issues versus what you saw in Rochester?
Great. Well, thank you so much for that question. You're right. Unfortunately, mental health care is often undervalued when it comes to compensation, and that is, has led to kind of challenges in accessing care. I would say the major difference that I experience here in Ontario in particular, there have been a number of measures taken over the last several years to open up access to care that is covered by our provincial health insurance. There is, again, more kind of coordination across silos. So I'll see a patient in my office who is struggling with depression or anxiety, for example, and one of my first steps will be giving them the phone number to my family health team, which is nurses, social workers, occupational therapists, and the mental health team that's part of that family health team is fully covered by OHIP and will offer counseling and then also connection with local resources. And then we also have provincially covered structured psychotherapy, cognitive behavioral therapy, for example, DBT, and then trauma-based therapies. And that happens because the province decided this is important and it needs to be addressed. And politicians were influenced by those who told them so, and so they directed money in that way. In terms of psychiatry consultations, there are a number of different options, and some have long wait times. No one was 6 months. I think that's super challenging. And so some of it is virtual care, some of it is local. And so that I think there are more options and more covered options that I really am more confident at getting accessing mental health care for my patients. It's not perfect, and it's much easier to get to have a psychiatrist consult once or provide consultation for the primary care physician to continue care than certainly to access psychiatry care for ongoing care. But our local psychiatric facility has been working hard at improving their access to the community at Waypoint Health. And so I think things are improving, not perfect, but things are improving and certainly much better than I experienced in the United States.
That answer your question, Christopher? Yep.
Would you say that's a qualitative difference? Because we struggle very much here. Like I'm on South Avenue. I deal where there's double stabbings outside. I deal with a lot of issues with folks. I'm just a little tack shop on South Avenue, but literally in catbird seat, what's happening. And people are struggling with mental health, and it doesn't seem that they're not getting connected. I mean, I've talked to people who run urgent cares here, and they tell me, "Oh, we don't want to deal with psychiatric. We don't get paid for that. We'll deal with a broken heart, broken leg, but not a broken mind." So
yeah, it is a challenge with compensation.
Yeah. Go ahead, Christopher. If you want to thank you very much, Christopher, for that phone call. And I take that last point that he's making there, Dr. Queenan, that the way healthcare gets categorized and what happens to psychiatric care, it's certainly still a crisis here. I mean, no surprise to you. Christopher is not wrong about that. Jim in Rochester has been waiting. Hey, Jim, go ahead.
Yes, hi. It was mentioned that there's a lack of primary care in Canada or in Ontario. And I was wondering what the Canadian Medical Society felt regarding those vacancies being filled by nurse practitioners or physician assistants, whether they were promoting that or whether that was something that was on the front burner in terms of trying to fill those vacancies to get more primary care providers available to see patients.
Yeah, good question, Jim. Thank you. Dr. Queenan?
Absolutely. I won't speak to the CMA's official stance on this because truthfully, I'm not sure of it, but I'll speak more to my own and my general gestalt. Certainly, I think that there is a broad recognition that we need more boots on the ground. And absolutely, some of those boots on the ground will be nurse practitioners. We're newer in Canada, in Ontario, about you for physician assistants. Their role is growing, and we're seeing them more working in hospital settings and emergency rooms and on inpatient floors. So I can't speak to the role of PAs in primary care, but certainly the role of nurse practitioners is growing significantly. Absolutely.
And I think let me see if Jim wants to jump back on that because I've got a question myself. But go ahead, Jim. Anything else you want to add there?
Well, I guess so that means that within Ontario, at least, your experience is that there are schools that are turning out nurse practitioners and or physician assistants. And are they directing them more? You mentioned physician PAs are more in the hospital and clinics, but are they trying to train them and direct them more toward primary care, or is it just sort of, that's where they sort of gravitate to, and nurse practitioners for some reason gravitate more to primary care?
Well, I think nurse practitioners really can go into a wide variety of areas. We have a nurse practitioner, for example, in our local hospital, a really valued nurse practitioners working on the inpatient floors with our medical teams. And so they certainly can, quite certainly go into a variety of different fields in the healthcare system. I think certainly being encouraged as in the same way that in medicine, graduates are being encouraged to go into family medicine and primary care. The problem is that the field is such a challenge right now with so many patients requesting care, this deluge of data that we are onslaught on a daily basis. that it sometimes just feels like more is being asked of us as primary care providers, both nurse practitioners and physicians. More is being asked of us than any human can deliver. And so it really is taking a step back and looking at the system and looking to see how we can make primary care a more attractive field for physicians and nurse practitioners to go to, rather than kind of a direction or kind of pushing them into.
Just about our last minute here, then, the extension to that, maybe this is a good way to close the program. I think some listeners would be surprised to hear that you have a very strong endorsement of making this move 10 years ago from the United States to Canada, that you feel that the mission and the values of Canadian healthcare are more reflective of where you want to be. And yet it's still tough sometimes to get enough time that would make you comfortable that you've got enough time with patients. And there's apparently a shortage of doctors at some levels here. And so is it because there aren't the people to fill those slots? Is it there isn't the money? The money is now short. There's enough money to hire. So what's the final diagnosis? What would change this equation, Dr. Queenan?
Well, I think primary care is in crisis the world over. And essentially, our systems have not yet caught up with the complexity that is the current human who is being kept alive much longer, but often with many more chronic illnesses, impacted by the foods we eat and our often sedentary lives, making the practice of primary care very, very different than it was in decades past. So I think that the prescription is recognizing that and moving towards what we are doing in Ontario, while preserving continuity that is so important with primary care, bringing in teams.
I just want to say, Dr. Queenan, I mean, I could have spent the hour just reading emails from your former patients in Rochester who love you.
Oh, you have to forward some of them.
It's really lovely.
I miss everyone.
And there is such love for what you did in this community when you practiced medicine here. And I'm really glad you took the time. Let's just do this every 10 years. How's that?
Sounds like a plan.
Or maybe more often. I appreciate it. Dr. Queenan, thank you for the time. You are generous with that. I wish you well, and thanks for being on the program today.
Thanks so much, Evan. I appreciate it.
Dr. Emily Queenan is a family physician at Queenan Family Medicine and Maternity Care in Midland, Ontario. We've got more connections coming up in just a moment.
This program is a production of WXXI Public Radio. The views expressed do not necessarily represent those of this station, its staff, management, or underwriters. The broadcast is meant for the private use of our audience. Any rebroadcast or use in another medium without expressed written consent of WXXI is strictly prohibited. Connections with Evan Dawson is available as a podcast. Just click on the Connections link at WXXInews.org.
Support for your public radio station comes from our members and from GreenSpark Solar, serving the greater Rochester and Finger Lakes regions for over 20 years. GreenSpark Solar is dedicated to helping people power their homes and businesses with local solar power and battery storage backup. More at greensparksolar.com.